let's get started.
Hi, could I have your attention? All right. The review from Friday, the video of that has now been posted to the iSite. All of the lecture slides through today are on the iSite. We don't have control over the videos. The most we can do is ask the media services office to post them as soon as possible. So that's part of the reason that you should come to class here, so that there's no question about when you can see this lecture and learn the material. For the midterm on Wednesday, this is just a reminder, you should have received an email from me about room assignments. This room can't accommodate everybody for the exam, so we're dividing up into 3 different rooms. Please make sure to go to the correct room. You'll get a reminder about that tomorrow night. And finally, today is the last day if you want to switch the course to or from pass-fail, or if you need an ad form signed. So please find me in the back of the room. Today's the absolute last day you can do that. Thank you.
Okay, so just to reiterate that, so there's no confusion and pandemonium on Wednesday, the exam is being administered in 3 different rooms. The first part of the alphabet, I think, is in this room, and the latter 2 parts are in rooms in Emerson. And we'll switch that around for the next midterm, so those of you that, and like my wife's maiden name with Z, you'll be in the here or whatever. So please don't come here if you're in the wrong room. Look up, just pay attention, and you can figure out which room to go to. There's been a couple of points of confusion. I've talked about this twice before, but I just wanted to reiterate that when we talk about the 3 ways of defining health that I discussed a couple of lectures ago, the statistical standard, the adaptive standard, and the social construction or normative standard, do not confuse the normality standard, which is the same as the statistical standard, with the normative standard, which of course relates to the word norms, which is the social value standard. Okay, those are different things. We've discussed that before. Also, there's been some confusion regarding terminology, the difference between the health transition and the demographic transition. That's confusion that's widespread in the literature. Some people, I take the health transition to be the whole process, which includes within it not only the changes in health across time, but also the changes in demographic processes, fertility and mortality across time. Some people partition and they say, well, the demographic transition relates to changes in the age structure of the population and mortality and so forth. And the health transition refers to just the health-related stuff, like the change from acute to chronic disease. That's not how I see it. I take the health transition to be the whole thing, okay? But you're not really ever going to be asked to, this is something you would be expected to not goof on, but something like that, you wouldn't be, we wouldn't be trying to ferret out a subtle difference in your understanding of health versus demographic transition. Okay, are there any questions? All right, so last time we discussed the contrast between the kind of terminal care people want and the kind of terminal care they get in our society, and we saw that Americans pay a lot of money for care at the end of life and have quite reasonable expectations about what that care should include, but alas, they're unable to get either what they want or, frankly, what they deserve. In this session, I'm going to be focusing on the problem of medical harm, or iatrogenesis. Iatro is the Greek root for doctor, and genesis, of course, from to cause or to originate. So iatrogenesis means doctor-caused injury or medical harm. And the question is, how extensive is this phenomenon of medical harm, and what, if anything, might be done about it, and how our patients and physicians are affected by it? Now, what did you guys make of Illich's strident critique? Here's what Illich had to say. This is the first paragraph of his book, Medical Nemesis. This is the first sentence. The medical establishment has become a major threat to health. The disabling impact of professional control over medicine has reached the proportions of an epidemic. Iatrogenesis, the name for this new epidemic, comes from iatros, the Greek word for physician, and genesis, meaning origin. Discussions of the disease of medical progress have moved up on the agendas of medical conferences. Researchers concentrate on the sick-making powers of diagnosis and therapy, and reports on paradoxical damage caused by cures for sickness take up increasing space in medical dope sheets. What do you guys think of that criticism? Who bought Illich? Yeah, in the back. Okay, so we could get into a sort of a definitional question. I understand that there's an intellectual difference between those phenomena, but would you see medical malpractice as a bad side effect of medicine, of medical care? If you go to the hospital and the doctor makes a mistake and harms you, would you see that as a kind of unavoidable but negative aspect of medical care?
Yes.
Yeah. So I think part of what Illich is arguing is he's saying, look, when we look at the benefits of medicine, we've got to like step back and look at the whole effect that medical care has. Not just the good it does your body, but the bad it does your body. And then he moves beyond that, and he's not just focused on its effect on your individual body, but he's after something else as well. What is the bigger thing he's after? Yeah.
Illich speaks about social iatrogenesis, so the way it changes our society and the way that people, once they're labeled with a certain diagnosis, no longer participate in society, especially if they have a mental illness, if they're diagnosed with a mental illness.
Excellent. So what Illich is interested in, as was just argued, is also this concept of social iatrogenesis. It's not just the way medicine affects individuals and their bodies, it's the way medicine affects the whole cultural milieu. It's the way medicine makes us incapable of experiencing our bodies except through a kind of medical lens. So this is a very strident critique that Illich is making, and we'll return to this. And I'll never forget this, because when I was in training to become a physician myself, one of the first weeks of internship, one of the very revered senior residents, these guys that we all looked up to and we thought they were unbelievable, he took me aside and he said to me, Nicholas, he goes, never forget, hospital admission is not a benign procedure. Don't assume when you see someone in the ER that only good can come to them if you admit them to the hospital. You could kill them by admitting them to the hospital, as we're going to see today. So hospital admission is not a benign procedure. Bad things can happen to people under medical care, and we need to take this possibility very seriously. Now, there are many different types of medical harm. For example, we can think about errors and mistakes. And an error or mistake is the failure of a planned action to be completed or the use of a wrong plan. That is, these are errors in execution or of planning. And an adverse event is an injury resulting from medical intervention rather than from the disease itself. And it typically involves an error. Okay, something bad happens to the patient, but it's not because of their disease, it's because of something that medicine has done to them. But not all errors lead to harm, and not all harms are the result of errors. There can also be something which we could just benignly call a maloccurrence. Okay, just something bad happened, no one was at fault, nothing bad was done, but there was a misadventure, sometimes called a therapeutic misadventure in the patient. And not all of these are, there's also this notion of negligence or malpractice, and not all of these harms are negligent, since negligence is judged according to local standards. Negligence is care falling below the standard of care in the community. So just because in the hands of the world's best surgeon a bad outcome would not have occurred, does not mean that the doctor whose care results in a bad outcome has been negligent. Okay? If I held every doctor to the standard that the care they give must be at the standard of the world's best practitioner in that particular thing that they do, then every doctor would necessarily be deemed negligent. But that's not really reasonable. Negligent is a local community standard. Like this doctor failed to act, was acting negligently by comparison to what's considered statistically normal in their environment. And finally, we have the problem of poor quality medical care, which subsumes all of the foregoing and much more. So there are all these different words that cover different aspects of the phenomenon of medical harm, and they have different sort of flavors of blame, different flavors of whether there is a mistake made or a bad outcome experienced, and so forth and so on. And Illich and others lump all of these under the term of iatrogenesis, or doctor-caused injury. And this term, iatrogenesis and medical harm, are the broadest terms. Now here's one way to group these kinds of events. So you imagine that there's some kind of medical error, and this medical intervention, and this intervention might involve an error or might have no error. Now, even in the absence of an error, and I didn't draw an arrow, could cause a sort of a bad outcome. There could be something bad happen. That might be like a maloccurrence, for example. No mistake was made, but something bad happened. But let's say there is an error, and the error is inconsequential, and the patient has a good outcome. Well, an error still happened, but nothing bad happened. Or there could have been something significant. The error was a significant error, and there was a potential for a very bad event. But lucky for the patient, the medical care system intervened, and there was still a good outcome. or there was a bad outcome which was preventable if the error hadn't occurred, and we're going to call that an adverse event. So an adverse event is an error that leads to a bad outcome. That's an adverse event. But if there's no error and a good outcome, we might say that's an adverse reaction. For example, if I give you a drug and you have an allergic reaction to it, okay? I didn't make a mistake. I didn't know that the drug would cause an allergic reaction. You suffer an allergic reaction from it, but you don't die, let's say. We're going to call that an adverse reaction. And in fact, there can be a whole variety of phenomena like this. The bad things that can happen to you while in the hospital or under medical care can run the gamut. This is an example of a rare but particularly nasty drug reaction called toxic epidermal necrolysis, or Stevens-Johnson syndrome, SJS. And in it, your skin literally sloughs off your body. You shed your skin like a snake. And it's an immune complex-mediated hypersensitivity reaction, and it can be caused by many drugs. So your immune system goes haywire, it attacks a certain layer of your skin, and your skin begins to peel off your body. And it can be caused by many drugs, but also by viral infections and sometimes even by malignancies. And when severe, this condition can be fatal between 3 and 15% of the time. So whether you would judge this condition to be merely an adverse reaction or a negligent adverse event would depend, for example, on whether the doctor should have known that the patient was allergic to the drug when it was given. So if I negligently didn't know that you were allergic to this drug and then give you the drug and then this course of events occurs, we're going to call that an adverse event. But if I don't know that you're allergic to the drug and I just give you the drug and oops, you suffer this calamity, that's just an adverse reaction. So we might use different terms to describe the same outcome. And adverse drug reactions, including severe ones like this, are actually not uncommon. And here's a paper that when I was a medical student here at Harvard Medical School years ago, a very famous physician who studies this topic called Lucien Leap came and gave a lecture. And I was at the Beth Israel Hospital at the time, and he presented this case: intratracheal fire ignited by an ND-YAG laser during treatment for tracheal stenosis. So this is like a condition where the person's trachea has become stenotic, it's become constricted, and in order to open it up, they put a laser down in there to kind of burn away some of the tissue. But of course, the patient has to breathe while this is happening, so they have to feed oxygen into you at the same time. And if you have pure oxygen and a laser in the same small space at the same time, sometimes you get a fire. Now think about this. This is a fire inside the patient's body, okay? And so this case, when I was told about this case, it just sort of blew my mind to consider that we could cause this much injury, both symbolically and practically, to the patient. So being in a hospital can indeed not be safe if we can even get fires inside people's bodies as a result of medical care. Here's another recent case from London. Man has a wrong kidney removed. Medical officials said on Thursday that doctors at a Scottish hospital had removed the wrong kidney from a patient during an operation. John Heron, who media reports said was believed to be in his 60s, had the healthy organ taken out during surgery at Ayr Hospital. It is with deep regret that I confirm that a patient being cared for in the Ayr Hospital has had a healthy kidney removed, said Bob Masterson, Executive Director for the NHS Ayrshire and Arran Trust. Our thoughts are with the patient and family, to whom we apologize for this tragic error. Staff are supporting the patient. It's kind of like closing the barn door after the cow is gone. Staff are supporting the patient and family in planning for the best possible medical care for Mr. Heron in the future, okay, after we've taken out the wrong kidney. In a statement, Heron's family said they were devastated by the disastrous professional errors that should never have happened. And actually, these cases are not unheard of. I tweeted the link to this study just a couple days yesterday. This is a study of 20 years' worth of malpractice claims in the United States that revealed the frequency of such so-called never events, events which should never happen. And so there were about a total of about 9,744 such never events in the United States in these 20 years. There were 4,857 where after the surgery something was left in the patient's body, an instrument or a sponge or something. 2,447 where the wrong procedure was done on the patient. Imagine you go in for a gallbladder procedure and they remove your kidney by accident. Or wrong site surgery, they take off your left leg instead of your right leg, oops. Or wrong patient surgery, they actually operate on the wrong patient. And what I don't understand about these data is why it's twice as expensive to do the wrong procedure as it is to operate on the wrong patient. I have no idea. I don't know why the payout should be more for that than for operating on altogether the wrong person. But in all seriousness, here's an interesting detail about the British case that appeared in another newspaper. And so highlight on the yellow there, it says, John said he told doctors minutes before the operation that the pain was on his left side, not on his right. But they had already marked his body with a pen and dismissed his fears, even though they had not seen vital x-rays showing the tumor was in his left kidney and not his right kidney. And in fact, the majority of these cases of wrong site surgery or wrong patient surgery are due to a breakdown in communication between the surgical team and the patient and family, according to the Joint Commission on Accreditation of Healthcare Organizations. Typically, emergency procedures, unusual equipment, staff rotation, and time pressure are also additional further causes of these types of disasters. Now, the need for improving communication is actually stressed to patients to the extent of even highlighting their responsibility to communicate with their doctors so as to avoid medical mistakes. Here's a tip sheet from the U.S. federal agency, a U.S. federal agency called AHRQ, on ways to prevent medical errors. And it mentions the problem of right part surgery. So it says, ways you can help your family prevent medical errors. It says, medical errors are mistakes that can happen with your health care. Medical errors can hurt or even kill people. And what can you do to make sure the doctor operates on the right part of your body? That's how you do care about that. And here's error. The doctor operates on the wrong part of your body. Here's how you can help with this problem. Talk to your doctor about the surgery. Ask what will be done. Ask where it will be done and the name of the surgeon. Ask if the surgeon does this kind of surgery often. Ask if many people have this surgery done at that hospital or clinic. People do better if they have an experienced surgeon. And ask your surgeon to make a mark with a pen before the surgery on the part of your body where the surgery will happen. Some doctors will sign with their initials on the right body part. Now, other tips from this little handy pamphlet to help you avoid having the wrong part of your body taken off include, be an active member of your health care team. Make sure all your doctors know everything you are taking. Make sure your doctor knows your allergies, and so forth. And in fact, the effort to involve patients in their care to help prevent medical harm can go quite far. The federal government, again, through the same agency, has some further suggestions. So here is a sort of another website, and it says, reducing medical mistakes. Patient safety is one of today's most pressing healthcare challenges. The most important thing you can do to improve your healthcare is to take an active role in your care. You can enhance the quality, safety, and effectiveness of your care, your diagnosis, your treatment, and any medications prescribed to you. Just ask questions, is the advice to the patients from our government about how they can help reduce the problem of medical care. And in fact, they've released this little video. Here's a little video called Questions Are the Answer. And I don't know if we have audio, but I want to make sure we have audio for this. I've plugged it in over here. So let's see if we have audio.
Any questions?
Oops. So let's turn up the audio. Can we turn up the sound in the back? Gabe, is there someone in the sound booth? Should be okay on the video? All right, here we go.
Any questions?
No.
You know.
No sound.
We're not magicians, we can't read your mind.
We meet your questions, each and every kind.
What are the side effects, doctor, doctor?
How many times have you done this before?
Well, the 3
love this one.
These tests even for?
You have the power to say what's on your mind.
We need your questions each and every kind.
Every time.
Questions are the answer. Questions are the answer.
Okay, so what strikes you about this video and the last few slides that I've shown you? What's interesting about this way of seeing the thing? Yeah. No one answered anything? Yeah, okay, good. That's good. Yeah. Yeah, it's interesting. There's something subtle is happening here, isn't it? And that's in it. What else? Yeah.
They weren't really doing like best practices if they're singing.
Oh, you're just a curmudgeon. They weren't doing best practices if they're singing instead of doing the procedure. They're going to be a medical error because they're rocking and rolling in the OR. No, I think the second point that was made, in addition to the first point, which is that even if people ask questions, if the doctors and healthcare providers aren't answering, we're not actually doing anything. In fact, if people, to the extent that physicians are defensive, that's really a bad thing. But also, there's a kind of a subtle and interesting shift that's occurring here, whereby the burden of responsibility and the locus of control for medical harm has been shifted from the healthcare system and the practitioners to the patients. Somehow, they are seen as the lever with which is necessary to push in order to attack this problem. And yet again, it suggests this kind of ongoing sort of variation or contrast between structure and agency here. Do the patients have the agency to stop medical harm, or is it instead due to the structure? Is it something beyond their control that has to do with the healthcare system more generally? And in fact, the problem of medical harm could get still worse. These are three pictures that probably you guys have no idea who these healthcare workers are. On the left is Charles Cullen. He's a nurse who admitted to killing at least 29 patients in 2006. In the middle is Dr. Michael Swango, also called 00 Swango. He killed 35 to 60 patients in numerous hospitals around the United States over the period from 1984 to 2000. And on the right is what I think is the world's most successful serial killer. This is Dr. Harold Shipman. He had 218 known victims in England from 1970 to 1998. Indeed, some of the most prolific serial killers have been doctors and nurses. If you go, don't go right now, but if you go to the list of world's most successful serial killers, I think 9 of the top 10 are actually healthcare workers. And the reason is that they have not only easy access to victims, but also they typically have no need to dispose of the body. Turns out any one of you who have seen, The Sopranos or any other one of these movies knows that actually when you kill someone, turns out a big problem is what do you do with the body afterwards? Any Hollywood movie will show this problem. Now, if you're a healthcare worker, you don't have that problem. So for a variety of reasons, it turns out the world's leading serial killers are actually healthcare providers. And often, there has been complicity of the hospital bureaucracy in cases such as this. There's this sense in which this phenomenon is an illustration of a broader kind, a kind of social iatrogenesis that I'll return to in a moment. And there is in some sense in these cases that the healthcare system can be seen as responsible for them, at least in part. For example, in both the Shipman and the Swango cases, and in others like it, subsequent inquiries revealed that the medical establishment, principally through apathy, actually protected the murdering doctors, often turning a blind eye to their activities, often in the name of preserving professional independence from external review. Licensing boards and other authorities refused to revoke the ability of such doctors to practice, despite compelling early evidence of such doctors acting in a fashion injurious to their patients. Typically, people didn't want any trouble. It was kind of like the scandal with the sex abuse among priests. They were just transferred to another hospital for them, get out of my system, go somewhere else, and they would go on and they would continue to kill patients in these other jurisdictions and keep moving from place to place. Now, these are all dramatic examples that I've been giving you, but most mistakes are much more mundane, and they typically involve things not like deliberate killing, of course, of patients, but they involve things like the administration of the wrong drug or some human or mechanical error that is, to a greater or lesser extent, either avoidable or unavoidable. And overall, mistakes, both minor and major, are not uncommon, and they occur across the whole spectrum of care from diagnosis to treatment. And the burden that medical harm imposes is indeed significant. So adverse events occur in 3.7% of hospitalizations. Hospital admission is not a benign procedure. 27.6% of these events are due to negligence, so most are not because the doctor makes a mistake or goofs. Most are sort of unavoidable, like doctors are trying hard to do the right thing. And 13.6% of these events result in death and 2.6% in serious disability. In fact, between 44,000 and 100,000 Americans die each year due to medical errors inside and out of the hospital. Medical errors are one of the top 10 killers in our society. Medical errors are one of the leading killers in our society. And the total costs are between $17 and $29 billion every year. And this rate of error and death is significant because there are more than 13 million hospitalizations each year in the elderly alone. So the 3% figure may not strike you as too high, but we have many millions of hospitalizations every year, so this is what adds up to this very large absolute count in harm that is caused. And these number of deaths, the number of deaths from medical errors, place medical error in the top 10 leading causes, somewhere between number 8 and possibly as high as number 5. So the number of deaths due to medical error is somewhere in this region here. Perhaps more of a killer than diabetes or accidents, but less of a killer than stroke or cancer. And in fact, and even at the low end of 44,000, more people die from medical errors than from motor vehicle accidents, than from breast cancer, or than from HIV-related diseases. In fact, about at least 4 times as many people die from medical errors as from AIDS every year. And in fact, every year, 6,000 Americans die of workplace injuries, but 7,000 die from medication errors alone. Just the subset of medical error where the patients are given the wrong medication kills 7,000 patients every year. Well, the question then comes, where do these medical errors originate? Do they originate in the structure that surrounds the patient and the doctor, or in the agency of the doctor? And where does responsibility for errors lie? Is it within the system, or is it within the doctor? And there's a tension between the idea of seeing the do no harm edict within medicine, the kind of ethical guiding principle, the Hippocratic Oath, do no harm, as a rule of personal responsibility, like, am I, Nicholas, Dr. Christakis, responsible for doing no harm? Or is the locus, is safety more properly seen as a kind of system property? The obligation to do no harm resides not within me, but within the total healthcare system more generally. Now, since some error is unavoidable, and since, in fact, error is intrinsic to the practice of medicine, physicians need to cope with it both pragmatically, that is, they need to find ways to reduce the occurrence of medical error, and personally, that is, they need to find ways to deal with its existence. How do any of you who plan to be doctors, like when I became a doctor, I had to struggle with a very palpable recognition that I might make a mistake which might kill my patient. You know, how do I practice medicine with that realization? How do I carry that burden? That's a different kind of coping than the idea of coping with the possibility that I might make a mistake to try to create systems or to adopt practices within myself that reduce the pragmatics of the situation, the actual occurrence of the mistakes. Well, let's start with a heartbreaking case outside of medicine. Every year there's a case like this in the news. This is the question is here, is this an error that warrants responsibility or blame, or a change in the system? Baby dies after dad forgot her in car. A baby died after her father forgot to take her to daycare Friday morning, officials told KPRC Local 2. Houston police said the father discovered his mistake when he got to the daycare center at Crawford Street near Rosedale Street in southeast Houston Friday evening. He was there to pick up his 7-month-old daughter and her brother, who was taken to the facility separately. Houston Police Sergeant Robert Blaine said he forgot about dropping her off and instead went directly to work at Rice University and parked in the parking lot over there. He returned around 5 p.m. to his car, drove back to pick up his son and his daughter at daycare, and upon arrival here at daycare, discovered the 7-month-old infant was in the back of the car. The girl was rushed to the hospital where she was pronounced dead. Investigators said they believe she died from the heat. Police said taking the children to daycare separately was a change in routine for the family. The mother dropped off the girl's brother separately because of swim practice. Detectives said they believed this was an accident. As of Friday night, no charges had been filed, and the investigation continued. And there were similar cases that have occurred, for example, in Virginia in 2008, and the father was prosecuted by the district attorney in that case. Can you imagine making a mistake that results in your child dying and then afterwards facing criminal charges as well? So this is clearly an error that has occurred here. But what do you think? What was the cause of the child's death, do you think? Was it the dad's actions, or was it the drop-off system? Raise your hands if you think it was the dad's actions that were responsible for the child's death. Raise your hands if you think it was a problem with the drop-off system. So this is a typical response, about 80-20 that we get every year for this situation. Now consider the possibility that you are a surgeon and you have a change in your routine. And this is in fact one of the prototypic kinds of errors that reason discusses in the reading for today, for which in principle systems might be in place to prevent this kind of mistake. So for example, what kind of systems might, well, we'll get to it in a moment. What kinds of systems might we want to prevent the example of this kid in the car? Let's say we wanted to prevent this from happening in the United States. Every year there are 1 or 2 cases of this happening. It's like the debate we're having about gun control, incidentally. You know, is it all about the agency of the shooter, or can we do something about the structure that prevents the shooter from killing, dozens of people when he or she goes on a rampage? We'll actually come back to that later. But the question is now, what kind of systems, if we said every year there are kids who die in exactly this way, and there are, what might we do systematically to prevent that from happening? Any ideas? Yeah. Yeah, so maybe a process, exactly. In our daycare center, we call to always check. We always call both parents to check, your baby isn't here today, what happened? Oh my God, the baby's in the car. Yeah, Dad would have, if you had called, if Dad had been called 1 hour later, that was system, and then the baby wouldn't have died. And then what would we have said about the dad's actions? We would have seen them differently. Yeah, another thought. Here, yeah. Motion detectors in cars. So when the ignition key is removed, a little device, we might invent a widget that prevents this from happening. For years, there was a problem of patients during anesthesia dying because there was an interruption in the oxygen flow. And if the patient is unconscious and there's no oxygen going to their body, by the time you recognize that the patient is a vegetable because they haven't been getting any oxygen, because you're breathing for them, you're pumping in air, but it's nitrogen. If I plugged you up to a machine and filled you with nitrogen, your chest would move, but you'd be getting no oxygen. I wouldn't have any way of knowing, and you'd be dead. And then eventually people started doing things like putting a carbon dioxide experometer, like a little device on the exhalation tube that monitors, is the patient exhaling carbon dioxide, right? That means oxygen's coming in, carbon dioxide's going out, alarm goes off if you're not. Or putting a little oximeter eliminates the problems. Why would we have blamed the anesthesiologist in bygone days for killing this patient when the simple introduction of a little device, a system change, would have prevented this problem? And the question then is, well, would they be worth it? Maybe equipping devices to prevent 2 such deaths per year, would cost billions of dollars for all the cars. Is that actually worth it? And finally, who should decide? What if people say, this is government intrusion in my private affairs? The government should not be able to force me to pay an extra $20 for a little sensor. That's ridiculous. I don't want that. Or do we say, no, that's not okay. We want people that are not just babies, but people that are mentally disabled or that are paralyzed or whatever. We need some way of detecting if they're in cars, so you don't get to decide what kind of vehicle you have. So I'd like to turn a little bit to the problem of blame, because 80% of you wanted to blame this poor father. I hope to change your minds about this. And in 2008, in the year 2000, there was a very influential report released by the Institute of Medicine, trenchantly entitled, "To Err is Human." And it identified several ways to reduce medical harm. And one of them was to recognize that medical care organizations should implement non-punitive systems for reporting and analyze errors. They said we should stop blaming doctors when mistakes happen in hospitals. And the reason we should stop is not because we want to be kind or forgiving or merciful to these doctors who may already feel terrible. No, the reason we should stop is because if we stop blaming them, maybe we'll be able to improve our healthcare system, because we'll bring blame out of the closet and people will more accurately report what's happening. And the IOM, the Institute of Medicine, and other official policy-making bodies and experts in medical error have been championing the need for a blame-free culture in medicine. with systems for detecting and reporting errors similar to other industries. In fact, it is commonly argued that the best way to uncover and reduce error is to promote a culture where no blame is ascribed to individual actors. Moreover, in this paradigm, most errors are viewed largely as system-based, not the serial killer mistakes, although even there, maybe the system just kept passing them along, but most errors are viewed as system-based and as impossible to eradicate completely and as infrequently traceable to truly negligent actions. In fact, blame in this model is seen as doing more harm than good. It's seen as engendering feelings of inadequacy or fear of punishment, and as ultimately pushing analysis and recognition of mistakes underground and limiting opportunities for improvement. So this is the systems perspective on medical error. A systems perspective on blame, in fact, for medical error. And it's in the systems perspective sort of says the best people can make the worst errors. This dad was a good father. He made a horrible mistake. Short-lived mental states, such as forgetfulness or inattention, are the last and the least manageable part of an error sequence. People will always make errors and commit violations, and blaming people for their errors will have no effect on their future fallibility. This is the sort of doctrines that guide the kind of systems perspective in medical error, like the driver and the baby. And two typical types of human fallibility include the following. So one is a kind of post-completion error, and a post-completion error is omitting the final step in a process, like leaving the original document on a Xerox machine. Have any of you done that? You go to Xerox or something, and you leave the document on a Xerox machine, you take your copy. You've committed a serious medical error. If you were a surgeon and you did that, you might have killed your patient. And yet most of you have done that. Or who here has sent an email and forgotten to attach the attachment? Okay? That's a miscompletion error. You do everything right, but the last step, you think, oh, I'm almost done, hooray, and you're leaving, and you leave an instrument in the patient's body. You forget to remove all the instruments, right? We discussed this at the beginning as a never event, and yet every single one of you has committed an analogy to a never event. Or a number thing is called another type of sort of thought process, a type of error, is something called a miscompletion error. And a miscompletion error, for example, is the following. You start a drive, and instead of taking a left where you're supposed to, you take a right, and you wind up at school instead of at work. So you're driving from Concord, where I used to live, to your office, and when you get to the Fresh Pond Mall, ordinarily if you're going to Cambridge, you're supposed to make a left and go up Garden Street, but if you're going to the medical school lab, you're supposed to make a right and go in the different direction. And some days you go one way, and some days you go the other way. Today you mean to go to the lab, but you know, there's a wonderful song, Call Me Maybe, is on the radio. And you're singing along with Call Me Maybe, and instead of going right like you're supposed to, you go left. And then you wind up at the William James Hall, and you're like, what the hell am I doing here? Oh my God, I'm in the wrong place, and you go somewhere else. So this would be like a surgeon opening you up. Usually when he opens you up this way, he does an appendectomy. This time he had to open you up a different way for some other reason, which is the way he opens you up when he's supposed to do a cholecystectomy. Oops, he does the wrong procedure. He's not a bad doctor necessarily. He's a human being, prone like the rest of us to this category of miscompletion errors. Or like, for example, if you set out in the morning and you think it's a Thursday and so you're going to physics and you walk all the way to your physics class, but actually it's a Wednesday and you're supposed to be at math. So you're in the wrong part of campus at the wrong day at the wrong time. Many of you have probably had these types of experiences. Here's an experience that happened on campus to me recently. This is a reenactment of an event at Forsheimer House. Here at Forsheimer House, this day they were serving my favorite meal, which is these chicken nuggets and tater tots. I'm not supposed to eat these things, and if Erica sees this video, she would kill me. But anyway, so what you're supposed to do when you go to the cafeteria is you're supposed to take a tray, you're supposed to place the plate on the tray, and then put the food on the plate. And here's the plates. You're supposed to take a plate from here and put it here. Then you put your hand here and take the fries and put them on your plate, but not me. I just forgot a step, you know? I did the wrong thing afterwards. If I had been treating a patient, I could have killed the patient from doing this, right? So what would be a system's response here? Maybe the trays should come with plates glued to them. So, you know, so you couldn't make that mistake. You would begin to think about this as, how do you organize a system to prevent Master Christakis from screwing up with his tater tots and making sure they wind up in the right location. Or maybe to follow Atul Gawande, we should have a checklist. So here's a checklist for getting your tater tots. Is the tray on the counter? Is the plate on the tray? Yes, yes. Is the food on the plate? Check. Proceed to the next station. And in fact, current thinking about the occurrence and prevention of errors focuses on a systems perspective. Now, I'm not sure that I entirely agree with the systems perspective, okay? I'm just telling you what it is first. But let me tell you a little bit about it. So the reigning paradigm is that we need a systems conception of medical errors. And this paradigm says that healthcare is a complex system. Errors and harm result from multiple faults and diffuse breakdowns. Humans are just one part of the system, right? And what's interesting about this is just like shifting the blame to the patients that we saw at the beginning, what's happening with the systems paradigm? Again, to the system. We're again finding a way to shift the blame away from the doctors. Take this blame away from me, right? And finally, error is an intrinsic part of the system. We say, look, people are going to have miscompletion and post-completion errors. They're going to forget to attach the attachment to the email. Maybe we need a little checklist. Every time you send an email, a little checklist. Did you mean to attach an attachment to this email? No, yes. Oops, I forgot. And you attach the attachment. And this argument, the argument in this perspective, is that healthcare is a complex and technological industry that's in fact prone to accidents. And in fact, when large systems fail, it's often due to multiple faults that occur simultaneously or together. And this is Reason's famous Swiss cheese model of medical error. So Reason imagines that there are successive layers of defenses in the healthcare system, different processes that take place. And this process has these possible mistakes that might take place, and this process has some other mistakes that might take place. And you only get a mistake where all the holes of the Swiss cheese line up perfectly. Like these defenses could stop. The doctor prescribes a medication, but the nurse reads the medication and says, that's the wrong medication, doctor. Stop. But maybe that day the nurse is a new nurse, so he or she doesn't know what to do, so administers the medication. You understand? So if there are repeated layers which could stop the mistakes from taking place, but an error occurs when all of these sort of mistakes line up and you get like the penetration of all of the defenses. And one of the greatest, and for a catastrophic error to occur, all the holes have to align for each step in the process, allowing all defenses to be defeated and resulting in an error. This is the systems perspective. The more defenses you put up, the better, and the fewer the holes and the smaller the holes, the more likely you are to catch or stop errors that might occur. So within each layer, we try to make the opportunities for failure smaller. Now, one of the greatest contributors to accidents, in fact, in any industry, including healthcare, is human error. But saying that an accident is due to human error is not the same thing as assigning blame, because most human errors are induced by systems failures from this perspective. Humans commit errors for a variety of known and complicated reasons. And we might begin to think of these errors, this propensity of human beings to make mistakes, we might begin to think about them as latent errors that we should design a system to prevent. And in fact, these latent errors can lead to operator errors, and the failures built into system failures in the system to prevent that might come to be seen as a kind of active error. And a typical example of a latent error is the packaging of two different medications in the same kind of ampule. So you have two different drugs which do two completely different things, but they're packed in ampules of the same shape and with the same little color band. And the doctor reaches to grab one of them, means to take the other, doesn't look, and pushes into the patient's veins a drug that's completely wrong at the wrong dose and might wind up killing the patient. And who can blame the doctor or nurse when they accidentally administer the wrong medication in such circumstances? And incidentally, the example of the father driving the kid to the wrong thing was a miscompletion error, right? Just like failing to attach the PDF attachment that we discussed. Any one of you could have made this mistake and killed your child accidentally. And the current response to errors tends to focus on active errors. And this is the point of this perspective, the systems perspective. But what we really should be doing is not focusing on the tip of the iceberg when these little errors occur, but further back in the process to try to see how we might prevent them. The application of human factor analysis in other industries has successfully reduced errors. Healthcare has to look at medical errors not as a special case of medicine, but as a special case of error, and to apply the theory and approaches already used in other fields, for example, the aviation industry or the nuclear power industry, to reduce errors and improve reliability. So the systems perspective believes that medical accidents are usually the result of complex system failure. And although incompetent and malfeasant staff exist, adverse outcomes are much more commonly the result of systems problems. And the argument in this perspective is that safety in medicine will not improve unless its complex system is redesigned. So this systems perspective has proposed various fail-safe devices and technical fixes similar to the changes implemented in the aviation industry, such as checklists and foolproof equipment design. Here's some suggested changes to parts of the system having to do with the administration of medication. So how are we going to keep doctors from, against their own intentions, making mistakes that harm patients? Well, let's have computerized pharmacy systems, or let's have automated dispensing cabinets, or let's have bar-coded drug selection, or bar-coded patient identification. Every time you administer a medication to reduce the risk you're giving the wrong medicine to the wrong patient, swipe the medicine and swipe the patient's little bracelet so you make sure you're doing it correctly. Let's have computer-generated or electronic medication administration records. Let's have electronic drug information, or let's have checklists of various kinds. So for example, there are many reasons for unclear medication errors that technological interventions, that is to say, modifying the structure, might fix. For example, dispensing errors can be made because medication names are misinterpreted. There are hundreds of thousands of drugs with similar names that can be confused and interchanged. So here's some drugs that those of you that become physicians will use. So there's quinine, 200 milligrams PO, that means by mouth, and quinidine, same dose, totally different drugs. Sulfasalazine and sulfadiazine, totally different drugs. Hydroxyzine, hydralazine, same dose, same route of administration, different drugs. Losec and Lasix, completely different. One treats hypercholesterolemia, one treats acid in the stomach, one treats congestive heart failure. Klonopin and clonidine, lamotrigine and lamivudine, I don't even know what those drugs are myself. Venblastine and vincristine, anti-cancer drugs, platinol and paraplatin, and so forth. Now, one of the things you can do is when this thing happens, you can rename these drugs. For example, Losec, they had their name changed to Prilosec. And when they changed the name to Prilosec, people stopped confusing Losec with Lasix and eliminated the likelihood that patients would do this. In fact, this point was recently driven home since last year by another event at Forsheimer House. So this is another reenactment. So my brother came to visit me, and he was sharing his bathroom with me, and I went one day to shave. And what I wanted to do is I wanted to take my shaving cream off my shelf. And unfortunately, my brother had brought a different product, which is shown on the left. These are completely different products. But they look surprisingly similar, and they have totally different uses. On the right, the product provides for ultimate closeness and ultimate comfort, and on the left, it provides for ultimate closeness and ultimate comfort, and on the right, it fights odor, relieves itching, burning, cracking, and scaling. So I reached for the Edge shaving cream, and I grabbed my brother's foot fungal spray, and I was about to spray my hand, and I was like, wait a minute, what's going on here? And it was the wrong product. Now, this is what happens, right? This happens to doctors, and they administer the wrong medications. So if this was a serious problem, we would pass a law that said that all shaving cream must have a green cap, and all foot fungus, medication must have a red cap that has little serrations on it, so we're absolutely sure that nobody makes this catastrophic mistake again. Please do not tell Dimitri that I told this story. So anyway, and there's another way that finally, there's another way that medical care can be harmful beyond one-on-one effects on the bodies of individual patients. Medical care can also impose a kind of collective harm. And this is one conceptualization of what is meant by social iatrogenesis. So there are at least two kinds of iatrogenesis. Actually, Illich describes three kinds, but for now, let's just focus on two. There's individual harm, and there's collective harm. There's kind of clinical iatrogenesis and social and cultural iatrogenesis. And a straightforward example of social iatrogenesis is the creation of drug-resistant pathogens that can spread in human populations. So for example, through the needless prescribing of antibiotics, and as patients come to expect antibiotics, even for conditions which don't respond to antibiotics, like you have a viral infection and you feel like your doctor's not a good doctor if he or she doesn't give you an antibiotic for it, even though the antibiotic doesn't help at all, because of the patient's demands and doctors' wishes to prescribe antibiotics, this has contributed to the emergence of a variety of very serious resistant pathogens: multi-drug resistant tuberculosis, drug-resistant HIV, methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus. These are bad germs for which we have no good drugs to treat, partly because we've created the selection environment for the evolution of such germs. So carelessness at the societal and institutional level, for example, with respect to drug policy, at the doctor level, for example, with respect to prescription behavior, and at the patient level, for example, with respect to drug seeking, result in this type of social iatrogenesis. And in fact, some drug resistance is clearly unavoidable insofar as organisms evolve even under the thoughtful and desirable use of antibiotics, but even here, greater care might be used to reduce the frequency with which this social iatrogenesis that affects our bodies, not just our minds. So the important point here intellectually is that clinical iatrogenesis affects our bodies, and social iatrogenesis can affect our collective existence, but both our physical existence, for example, we create these types of pathogens which kill us, and also, as Illich argues, our kind of mental state, our outlook and disposition on the necessity of healthcare. And nationally, the Centers for Disease Control estimates that there are as many as 2 million nosocomial hospital-acquired infections from all pathogens each year, and 90,000 deaths. 90,000 deaths from nosocomial infections. So nosocomial infections alone would be in one of the top 10 causes of death. Now, Illich, of course, makes a much more subtle argument and means something different, as I've just been saying, and broader with respect to social iatrogenesis. And his critique of medicine is strident and compelling. Social iatrogenesis, he argues, is over-medicalization or the expropriation of health. It occurs when people are encouraged to use doctors for more and more trivial problems. And it captures the tendency of medicine to damage health not via individual bodies, but by affecting the total social milieu. And he goes on, in fact, to describe another kind of iatrogenesis, which he calls cultural iatrogenesis, which even destroys the human ability to deal with human weaknesses. People, he argues, can become distanced from their lives, from their own humanity. And here, medical interventions interfere with the authentic experience of our bodies, of suffering, birth, and even death. And writing in 1976, he anticipated and was very critical of the system's perspective on medical error. This is what he said: "With the transformation of the doctor from an artisan exercising a skill on personally known individuals into a technician applying scientific rules to classes of patients, malpractice acquired an anonymous, almost respectable status. What had formerly been considered an abuse of confidence and a moral fault can now be rationalized into the occasional breakdown of equipment and operators. In a complex technological hospital, negligence becomes random human error or system breakdown. Callousness becomes scientific detachment, and incompetence becomes a lack of specialized equipment. The depersonalization of diagnosis and therapy has changed malpractice from an ethical into a technical problem." And so this is the dilemma today. Which way should you see medical error? As an agency issue or as a structure issue? As an issue of personal responsibility or as a systems problem? It seems that there is plenty of blame and responsibility to go around at all levels, and in fact, doctors are willing to take blame because they also want to get credit. Thanks.